I would like to start by thanking the organizers of this meeting for the kind invitation to be here. It is, for me, indeed a true privilege to be on the program of such a prestigious symposium. Very much appreciated. In 2013, I relocated from the Antonie van Leeuwenhoek Hospital in Amsterdam to the Melanoma Institute Australia. And initially I was afraid that I would have trouble getting to know the Australians. That proved not to be the case. In fact, the opposite happened. The Australians have trouble getting to know me. And so this will obviously take some time. It's all true. Now my topic is the Sentinel node procedure in patients with melanoma, and I will mention some technical aspects, but more importantly, melanoma is unique in the sense that we performed a randomized trial to determine the relevance of sentinel lymph node biopsy in these patients. We really wanted to have hard evidence that it worked, and that will be the mainstay of my talk. The sentinel node concept of orderly progression of lymph node metastasis is exciting and appeals to the surgical frame of mind. It's hard not to be swept away by lymphatic mapping, yet this is exactly what happened. Its momentum caused people to get carried away by their enthusiasm, and the procedure was instantaneously embraced by the surgical community and immediately made into a standard, a routine procedure around the world. So the way sentinel lymph node biopsy was introduced is much like other new operations were introduced in the past, and that is without much scientific evidence. And as a result of this early and rapid embracement, the unanswered questions quickly became evident. Many questions. Most importantly, of course, would there be a survival benefit? But also one wonders about, would there be false negative cases, and if so, how many? And what about complications, also important in surgical procedures? And do all patients, even those with minimal metastasis, need a completion node dissection? These unanswered questions led to opposing views that were vigorously debated at medical conferences and in prestigious medical journals in various fields. Well, I will discuss the issues that I just raised in relation to the multicenter selective lymphadenectomy trial number 1, the one that I just alluded to. The final report was published just over a year ago. Randomized studies of therapeutic procedures are very common, but randomized studies of diagnostic procedures are unusual. Yet it was thought that this approach was justified in case of sentinel lymph node biopsy, which is a diagnostic procedure, because of the importance of the issue, because of the radioactivity involved, because of the expensive equipment that is needed, and because for a diagnostic test, it is fairly invasive. So that's how the randomized study came about. 17 prominent melanoma centers from around the world participated. The study started January 4, 1994. Patients with a melanoma and a breast thickness of at least 1 millimeter were eligible, or thinner lesions if Clark level 4. 2,001 patients are in the study, and they were divided in 3 groups. Those with thin lesions, those with intermediate thickness lesions, defined here as 1.2 to 3.5 millimeters breast thickness, and those with the thick lesions. Now, the patients with thin lesions were a small group in the trial, and also thin lesions tend to recur late, if they recur at all. So in fact, what happened was that the number of deaths in the category of patients with thin lesions was too small to allow a meaningful analysis, and these patients are not further reported in the article. So we are left with the 2 other categories, those with intermediate thickness lesions and those with the thick lesions. The last patient entered the trial March 31, 2002. All patients were followed for 10 years. Now, I mentioned that the design of the study was somewhat unusual for surgeons, and that's the reason that the statistical tests that were used are elaborately described in the article. And one of the tests that were used is the parametric accelerated failure time latent subgroup analysis. And this is its original publication. And I would love to explain this test to you in detail, but I very much regret that unfortunately we're running over time, so I cannot explain the test today in detail. You should not believe everything I tell you. But suffice to say that the statistics were highly refined. The patients were randomized to one of two arms. Either they underwent sentinel node biopsy, and if the node was tumor positive, well, then an early immediate node dissection was carried out, or the patients were observed, and then when a palpable nodal recurrence happened later on during follow-up, well, then the node dissection was carried out at that point in time. The two arms of the study were very well balanced in terms of the usual prognostic factors like breast thickness and Clark level ulceration, primary tumor site, age, and gender. The sentinel node was identified in 99.4% of the patients, which is a pretty good number. Now, earlier studies that were carried out at the MD Anderson Cancer Center in Houston and at the Netherlands Cancer Institute in Amsterdam had already shown that the tumor status of the sentinel lymph node is the most important prognostic factor. And this was indeed confirmed in this randomized study. The tumor status of the sentinel node is the strongest prognostic factor in terms of disease recurrence and death from melanoma, and it outranks the more familiar prognostic factors. 10-year disease-free survival. In the patients with the intermediate thickness lesions in the sentinel node arm, 71% compared to 65% in the observation arm. In the patients with the thick lesions, 51 versus 41%. Statistically significant differences. And in this case, what this reflects, this benefit, is largely a reduction of nodal recurrences, obviously. Subsequently, the article focuses on the target population in the study, the node-positive patients with an intermediate breast node thickness. These are the really interesting patients. These are the node-positive patients who still have a relatively low risk of having distant metastasis. So these are the patients for whom the procedure is actually meant. Does the watch and wait observation period, during which an occult lymph node metastasis grows to detectable palpable size, permit metastatic spread to other nodes? Well, if you look at the average total number of involved nodes in patients with a positive sentinel node who underwent an immediate node dissection, that number is 1.4. But this number increases to 3.3 by the time that the metastasis becomes palpable. So the answer to the question is yes, indeed, in the watch and wait observation period, the period that it takes for an occult metastasis to grow to detectable palpable size, the disease does spread to other nodes in that very nodal basin. And we know from the AJCC-ICC staging classification that the number of involved nodes is a very important prognostic factor. And this shows when we look at 10-year melanoma-specific survival, which is 41.5% in the observation arm, but increases by half of this to 62.1% in the patients with a positive sentinel lymph node. So apparently what happens is that in the time that it takes for an occult lymph node metastasis to grow to detectable palpable size, the disease also spreads from this growing lymph node metastasis to other organs. And it is the metastasis in the other organs, the vital organs, that cause the big problems for the patients down the line. Now this to me is the most important outcome of the study. Let me show you this in a more graphic version. 10-year melanoma-specific survival in node-positive patients with the intermediate thickness melanoma, a clear separation of the two curves. And these are the patients for whom the sentinel node biopsy was developed. So these are the patients in whom the sentinel node biopsy should make a difference. These are the patients in whom the sentinel node biopsy, combined with a completion node dissection, should improve survival. And a 20.6% increase in disease-specific survival, well, that is exceptional in oncology. So this is an important point that I would like to bring across. Now, this beautiful survival benefit that we see in the patients with the intermediate thickness lesions is not seen in the patients with the thick lesions. In these patients, the numbers are very similar. So apparently, these thick lesions have already spread or have already generated distant metastases at the time that they are diagnosed, and it is these distant metastases, as I said, that cause the patient's demise in the end. Now we get to the perceived downsides of the procedure. Again, we're looking at the intermediate thickness lesions, now at all patients in this category, so that's node positive, node negative combined. And when we look at 10-year melanoma-specific survival, 81% in the sentinel node arm, 78% in the observation arm. Now, I'd like to see a trend here, given the sheer size of these two groups, but it did not reach statistical significance. Yet, if we look within this entire group at the node-positive patients, and these are the numbers that I just showed you, there is a statistically significant survival benefit. Now, these two contrasting p-values, they sometimes lead to confusion. So let me try to clarify this point. This p-value may lead some people to conclude that the trial is a negative trial. That would have been true had we been talking about a therapeutic procedure. But the sentinel node biopsy is a diagnostic procedure. It's not a therapeutic procedure. The purpose of the sentinel node biopsy is not to improve survival directly. Its purpose is to identify among all patients, the yellow patients, the ones who have lymph node metastases, the brown patients. The purpose of the sentinel node biopsy is to identify the 20% minority of node-positive patients so that these patients can subsequently undergo their therapeutic procedure. That should improve survival, and that's exactly what happens. So if you look at this entire group, what happens is that the survival benefit in the target 20% of patients is diluted by the other 80% who do not have lymph node metastasis. Patients without lymph node metastasis have nothing to gain from sentinel node biopsy in terms of survival. So that's one reason for the lack of a statistical significant difference here. And another reason is that the number of deaths in the study was fewer than what was anticipated, which reduces the power of the study. And a third reason, that's the false negative patients. And that's what I want to discuss next. False negative means there is a lymph node metastasis, but it is not identified by the sentinel node procedure. The patient does not undergo a node dissection and develops a nodal recurrence later on. Well, the false negative rate in our study was 20.3%. So here we are. 17 prominent melanoma centers, and we missed the sentinel node in 1 out of every 5 patients. That's not something that we are proud of. However, even if we take this into account and consider all patients, so that's node negative, all node positive patients, so that is true positive and false negative combined, still there is a statistically significant survival benefit despite the high false negative rate. That is how strong the data in the study is. Now you may wonder about the cause, the reason for the high false negative rate. My suggestion is that it is for a considerable part due to lack of experience in the beginning of the trial, in some centers at least, among surgeons, among nuclear medicine physicians, among pathologists. And to give you an example, in some centers in the beginning of the study, the surgeons only used blue dye. So no radiopharmaceutical, no preoperative lymphoscintigraphy, no gamma ray detection probe. And consistent with my suggestion is that during the trial, the false negative rate came down. And I think that a further reduction in false negative rate is to be anticipated, given the more extensive experience that is now present around the world, given the opportunities for education and training. That's why we're here today. And because of the ongoing refinement of the technique, and that's what this symposium is all about, the ongoing refinement of the technique. An earlier analysis had already looked at morbidity and mortality. There was no postoperative mortality. Morbidity 10.1%, which is a substantial percentage for what we like to call a minimally invasive procedure. But these were not serious complications, largely seroma at the sentinel node site or infection that could easily be treated with an antibiotic. At our Melanoma Institute, we recently had an audit looking at our postoperative morbidity of this procedure, and the number is now 1.8%. What are the implications of this trial for clinical practice? Well, the sentinel node biopsy is now recommended for patients with a clinically localized melanoma of intermediate breast thickness. Flat out recommended. And this firm recommendation is based primarily on the survival benefit in these patients. Also, identification rate close to 100%. There is more accurate staging. There's better prognostic information, less recurrences. And these advantages, of course, need to be weighed against the disadvantages, like a single-day admission is what we usually do. General anesthesia is what we usually do. There is morbidity, but it is not that bad, and I have reason to assume that it is decreasing, and the same can be said for the false negative rate. Now, what about patients outside the intermediate thickness range? The sentinel node biopsy may be recommended for patients with thick lesions. Note the more restrained phrasing, not flat out recommended, may be recommended. And this more careful phrasing is based on the lack of a survival benefit in this category of patients whom, as I said, have oftentimes already distant disease, which causes their demise in the end. So their fate has been sealed. It does not make a difference whether or not these patients undergo a node dissection. The other pros and cons remain the same. The sentinel node biopsy may be considered in patients with thin lesions. Again, more careful phrasing. And this more careful phrasing is based on the fact that the issue whether or not there is an improved survival in these patients is unresolved. As I said, the number of patients was small, the number of events was not sufficiently numerous to warrant a meaningful analysis, so we just do not know. What we do know is that 5% of these patients with thin lesions have lymph node metastases. So a routine sentinel node biopsy would have a low yield. However, there are many, many such patients. And I like to think that these node-positive patients would benefit in terms of survival because their risk of having distant disease is still so low. So the lack of scientific evidence is keenly felt here. Identification rate would be excellent, of course, in these patients. More accurate staging, yes. Prognostic information, again, we are not informed. A reduced risk of recurrence, likely, but we do not know. Now, at the Melanoma Institute Australia, we do consider sentinel node biopsy in these patients with thin lesions in the presence of adverse prognostic features like young age, ulceration, high mitotic rate, microsatellites, very important prognostic factor, lymphovascular invasion, and amelanotic melanoma. And these implications, as I outline them, they concur with the American evidence-based guidelines that were put together by the American Society of Clinical Oncology and the Society of Surgical Oncology. Now about imaging. Imaging for melanoma patients undergoing sentinel lymph node biopsy has been limited to preoperative dynamic and static lymphoscintigraphy with radiocolloids until now, basically. And now we have these new fascinating tracers, and we have these innovative imaging technologies. Well, the thing that I like very much is the SPECT-CT. This gives us the opportunity to cut tomographic slices at every level we wish. And we can look at sentinel nodes from every angle we desire. I appreciate the correction for scatter and attenuation that imply an improved sentinel node visibility. We see more sentinel nodes, we have better information as to the location of the sentinel nodes. You know, we surgeons, we want to see the anatomy, right? Well, now we see the anatomy. We see the sentinel node in its anatomic habitat, and that makes the procedure a lot easier in the difficult cases. Now, melanoma is a skin cancer, and lymphatic drainage from the skin is abundant. And lymphatic drainage from our intradermally injected tracers is abundant. The lymph node basins that are important to us are on the outside of the body. So what I'm trying to say is that with the conventional approach, we can find a sentinel node in almost all patients, and usually within 10 minutes. So in melanoma, there is not much need for more advanced technology. Having said that, the new technologies are very useful in the really difficult cases. And if there would be a substantial improvement that would make the procedure considerably easier, I'm certain that it would catch on. I come to my concluding remarks. The multicenter selective lymphadenectomy trial has reinforced the role of sentinel node biopsy in more accurate staging, better prognostic information, reduced risk of recurrence, and an improved, now there is solid scientific evidence of an improved survival in node-positive patients with intermediate thickness lesions. New tracers and new technologies. SPECT-CT is what you really want to have. The other new tracers and technologies are of lesser importance in melanoma. I think the potential of these new developments is that they will that they are opening up other cancer types to sentinel node biopsy, cancers deeper inside the body, cancers with a more intricate anatomy, cancers with a more complex lymph drainage pattern. I think that's the potential, the main potential of these new developments. And one important conclusion is that radio-guided surgery, now there is solid scientific evidence that it does improve survival considerably. And that's a statement that I would like you to enjoy over the weekend. Now, in closing, I would like to say that for me as a melanomologist, these are exciting times, and the prospects have never been brighter. And I am convinced that we will see wonderful things happening in the future, and radio-guided surgery will play an important role in this future. Thank you.